So, skin is the largest organ. It is one of the most important organs. It's an organ that we don't really talk about when we get into nursing. We talk about it for a skinny minute. We address it all the time, but we start to focus on the heart and the lungs and the brain and all of those things that keep us truly alive. But what you've got to understand, if our skin, the largest organ that protects our entire being, is compromised, it can cause major issues and even result in death if we're not careful. So this is just a really quick review from my students on tissue integrity and looking at the skin and some issues with that at a fundamental level. And so let's get started. So when we're looking at skin, one of the things as nurses, we want to try to prevent breakdown. One of the things that we do is we need to assess our skin every shift, sometime during the shift. It takes a while to look at it very carefully and going from head to toe. Sometimes our jobs just don't allow us to have that time right there in the first thing in the morning. But make sure that sometime during your shift, you are eyeballing your patient's skin and looking at all the bony prominences and places where skin breakdown really does happen. And where is that for most people? Well, if they're on oxygen, look behind the ears, because right behind the ears, they're going to break down right there. That tubing against that little bit of thin skin breaks down very quickly. And so we can have major skin breakdown there. What can we do as nurses to prevent that? If we have a patient that's using oxygen, their ears become red, or they say it bothers them or hurts them, or they're going to be on oxygen for a while and you are already seeing this coming, then you can take gauze and wrap around the tubing to put behind the ear there to kind of cushion that. It's important that we protect that area, and the way to do it is to soften or create a barrier with gauze or something else. That they have little things out there now that you can use, but to put that around an easy fix just right behind the ear and prevent the breakdown. The other things that we can do is we can use the Braden scale. And so you want to, and it is, I think, in compliancy for most facilities, is to do a Braden scale on your patient every day per shift. So you want to do your Braden scale. Make sure that you're looking if they are at any risk for breakdown. For my students, you need to now start to use the Braden scale in your clinical. So when you're in clinical, do your Braden scale looking at these things. Are they getting the proper nutrients? Are they able to move? Are they able to walk? Are they able to do all of those things? Because what that's going to do is flag you if they're at a high risk. If they're at a high risk, then we need to implement nursing interventions to prevent breakdown. So vitally important. Um, Monitor for your redness, swelling, and open wounds, of course, over those bony prominences. The other bony prominences, don't forget your elbows, heels of the feet, outer ankle, that little bony prominence on the outside of the ankle there. Any knees, any kind of joint that doesn't have a lot of tissue, fat, anything. And then just remember, of course, our sacral area and the perineal area, because those are areas that stay moist. There's pressure continuously on that back side when we lay in the bed or sit in a chair. So we want to make sure that we're checking all of those areas on a daily basis. Reposition your patients every 2 hours in bed, and if they're in a chair, reposition them too. Sometimes what we'll do is we'll get up patients, put them in the chair, and then not move them again, right? We need to go in, and even if it's just a slight little pillow to offload or a pull, you have someone help you kind of create a shift in weight, so that you shift them almost from one side of the buttocks to the other, then you have created and shifted that weight off to hopefully prevent some of that pressure. The one thing that you do want to make sure that you do is, if your patient is able, if they're capable of shifting their own weight or moving themselves, rolling themselves side to side, shifting, repositioning themselves in their bed, to make sure to remind them, because sometimes when people get sick, they freeze. They like just, I'm not going to move because it hurts, or I'm not going to whatever. You need to go in and make sure that you assist, or ask them to go ahead and reposition themselves while you're in the room. If you need to yourself reposition them, always make sure you float the heels, even if they can reposition themselves. Lay in bed for a while. Go ahead and sleep in, and then while you're awake, just lay there for hours and don't move. See how that feels and see where you hurt. And that will give you a great idea of how bad and how much pressure is there. So one of the things we forget about are heels, even for patients that can reposition themselves, float them anyway. Floating heels doesn't mean you put the pillow where the heels sit on the pillow. You put them behind that ankle, behind the heel of the foot, so that the heel floats, meaning it's not having pressure on a pillow or the bed. I hope that makes sense for everyone. Do you use foam wedges, anything to help offload pressure on those bony prominences? And once again, you see the heel protectors. So back to skin breakdown and prevention. We want to keep that skin clean and dry, and you don't want to scrub it like you're scrubbing your kitchen floor. You want to make sure you use a mild soap and warm water and pat dry. Don't rub or take the towel and down the whole skin, because all you're doing is causing shearing, and you can create small tears. You can create other breakdown and fragile skin that didn't need that kind of abrasive move. You can apply moisture barrier creams to protect against incontinence, which is associated with dermatitis. Ding, ding, ding for my students, dermatitis. What do we want to do? If they are incontinent, we need to keep them clean and dry. I am so thankful for whoever invented Pure Wicks. They can cause breakdown too if you're not careful. You need to be very careful with them. But they are a great device where if you have an incontinent patient and your facility is trying not to place indwelling catheters, you can use the Pure Wick and it will keep them dry. It just suctions the urine up into the wall canister. Just make sure that you check placement of those every time you're in the room. Just take a peep down there, make sure it's still in place, because you don't want to be fooled by that, because if it's not in place and there are getting moisture down there, then you have another something laying against the skin that can cause another issue for breakdown. Encourage a protein-rich diet. We need to make sure they're getting the nutrients, because skin, hair, nails, everything in our body for healing has to have nutrients, but for maintaining has to have nutrients. One of the things that we saw a long time ago is when people made these major diet changes, right? And they took all the fat out of their diet. Well, we have to have healthy fats to maintain our skin and our hair and our nails. So making sure they have protein, that they have the healthy fats, those things have to be in the diet to maintain skin integrity and promote wound healing. Also, we need hydration. And let's go back to the elderly client. When we're looking at the elderly client, do they eat enough protein? Do they drink enough fluids? And the answer to that is no. On most likely no. And the reason why is in our brain, we click off that drive to drink. We also, a lot of the elderly are on diuretics, so we're going to be pulling fluids. So we need to make sure they maintain hydration, but not overload. There's fine lines. So when we're looking at congestive heart failure patients or anybody that needs fluid pulled off, then we're going to have to back off of fluid. But most elderly patients are pretty dry. So just getting that baseline of what they need for the day we need to make sure as nurses that we're giving them those fluids. And then mobility. They need to move. You've got to move to take pressure off, walking to get blood flow. All of those things are vitally important. If a patient can understand and move themselves, if they can get up and walk, if they can move themselves and adjust their weight in chairs, if they have that understanding and are capable of doing it, they need to do it. We need to encourage that, and then also know they most likely will not have skin breakdown. But those that are laying in the bed, unable to move themselves, unable to even comprehend moving themselves, are the ones that are highest risk. So we need to make sure we intervene. So let's talk about melanomas. So this is a hodgepodge kind of situation. We've got a little bit of here, there. We're looking at fundamentals nursing tissue integrity. So with melanomas, the thing that we really need to know is that we use the ABCDE rule: asymmetry, border irregularity, color variation, diameter, um, greater than 6 millimeters, and evolving changes. We want to make sure that we share that and instruct our patients on that, because they need early detection is the key thing with melanoma. We need to find anything abnormal on our skin and go to a specialist, a dermatologist, to make sure we are checked out, that if it is a suspicious smaller lesion, that it is biopsied or removed, and that we know what is happening with that, and if it is, that we can intervene and hopefully prevent any spread of melanoma. So risk factors, let's talk about it. Let's not get out there in the sun. There's no more sunbathing like we used to do. Back in the 80s, it was betadine and baby oil. We slathered that stuff up and laid in the sun. It is dangerous. It is not appropriate for skin health. And so what we need to do is make sure that we talk about UV exposure and protection using sunscreens. They've got sunscreens out there, guys, that are 99 baby proof stuff. Bullfrog, Blue Lizard, those are some that are out there products. There's a ton out there. I just name those because those are the ones I know. But if you go out there and look, there's usually a whole wall of sunscreens, especially as it becomes spring and summer, because they know people are going to buy it and need it because we're out in the sun and we're trying to protect ourselves. But at least SPF 30 plus, but I am going with 50 plus, and I think dermatologists would say use the sun protective clothing. They have clothing that is impregnated with protection so that you are not getting those rays through, because you can get that even through clothing, and you need to understand that. So we need to protect ourselves. Hats are our friend, large brim hats, protecting our nose, ears, anything that gets the main amount of sun exposure. We want to make sure we do that. And then also, if you are fair skinned, family histories or immunosuppressed, there's medicines out there that will tell you it can cause major sunburn. Stay out of the sun. A lot of things for our skin that we take, some of the medicines to prevent acne and stuff, those medicines can cause these issues. So we need to make sure, if you read that we take extra precaution in wearing shirts and clothing and staying out of the sun. Also think about high sun times. When is it the hottest of the sun? When do you get the most exposure? But then also telling your patients, just because you wait till evening, you're still out there. So protect yourselves. An ounce of prevention is worth a pound of cure. It goes back to this, especially with this. We want to make sure that if we do have a mole or lesion that is removed or biopsied, that we do provide wound care for that. And ding, 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 that is something for my students to understand, is wound care. What are we going to do for wounds? How do we provide care for them? Do we put a dry dressing? Do we need to do a wet to dry? But when we're doing those, what are we doing? But we want to protect the wound from what? My advice for my students is go back and review wound care that you had for lab. There is a whole module on wound care. Plus, you went through skin assessment, and it'll talk about things. So just make sure you're focusing on that. We need to make sure we send them for early detection. Go to the dermatologist or your dermatology provider. It could be a practitioner of any form that's going to do a whole checkup, look at a whole body assessment, looking for any irregularities, removing biopsying and checking for anything irregular that could lead to skin cancer. We don't want it. No melanomas, no basal cells, no any of the other skin cancers that are out there. And then, of course, if they do have a diagnoses of cancer, of some type of skin cancer, we want to provide always, as nurses, emotional support, and usually plugging them into folks, but being there with them when the diagnosis is given, helping give them, holding a hand, and then providing the information where they need to go for follow-up. And usually wherever they are getting these diagnoses, or if you're in a hospital, those things are there for you to access and provide for them. There's support out there for these folks. So melanomas, ABCDE rule, always make sure, always checking yourself, know what that rule is. We need SPF. Let's protect ourselves with clothing and sunscreens. Stay out of the sun if you can. Stay out of the sun at the hottest, most direct sun moments. Noon, 2 o'clock, those times, those are prime times. Let's not go out during that time. Let's come in. But you are still exposed at early morning. Once the sun comes up to the sun goes down, there's exposure. Sharing with your patients this information. And then make sure that they know to eat well, drink, hydrate for wound healing, because that is considered a wound once we do a biopsy. So we want to make sure we provide the proper wound care just for these patients also. Next is staging wounds. And I'm just going to say this because there's so much to this. And you want to go back, review what each stage looks like. So if you have a stage 1, if the doctor or provider says stage 1, stage 2, stage 3, stage 4, what are you looking at? What do you see in the wound? Is it just red but blanchable? Is it red and non-blanchable? What are we looking at? And then if it's a non-stageable wound, know and understand what that is. Also, too, I want to say this to everyone out there. Do not stage the wound if you have a provider that is looking at this patient and or wound care nurses, walk nurses. If you have a wound care team in your facility, do not stage a wound. This is for everybody out there. If you have a wound care nurses, True Walk, a wound care nursing department, let them put in an order to ask the physician or provider if you can consult. Most facilities have that as an automatic that a nurse can put in for wound care to come see this patient. Let these nurses come in and assess and let them stage the wound. Two things with this. One of the biggest things, we as nurses that are not have had in-depth training miss stage wounds all the time. So by doing this, what happens is it becomes a part of their legal record. You're saying this is a stage 2 and truly it's a stage 3. Or you're saying this is a stage 2 and it's a stage 1. You know what I'm saying? It just happens. And it's not an insult to us. It's just that we have people out there, nurses that have gone on and done extensive training. So let them stage these wounds and stage them correctly, because I'm going to tell you what happens. When they are staged incorrectly, the hospital or facilities will take a ding for this. One, the care isn't going to be provided for the correct stage. Two, the payout for Medicaid, Medicare, and insurance will not be provided if it is staged incorrectly. The hospital will take a hit for this. And so because of that, I'm saying to you, just don't do it. When your notes, if you find something, describe it exactly what you see. Just describe it, what it looks like. Is it red? Is it got yellow exudate? Does it have black necrotic tissue? And if so, where? Use your clock. Midnight is the head, 6 is the feet. But describe it and measure it. Put it in your notes, and then consult the wound care team to come and take a look at it. Or share that with the provider if you don't have that, and let them stage the wound. Once the wound is staged, then you can put that staging in your notes all you want, because it has been legally or someone that's been trained has staged it. And I'm just saying this so that you don't make mistakes, so the hospitals don't take hits and the patient care is provided adequately and accurately so that they will heal. Hopefully the healing can be provided. So for my students, review what they look like, what they smell like, whatever. There's not a lot of smell. With infection, you get smells, but you'll learn that in the real world or as we move along as you're in the clinical setting. But infected things stink. I'm just going to go on record. So just look what it looks like, how to measure it, and then how to identify what it is. So if you see, I'm not going to have you stage in real world, but on testing purposes, there is a staging, if that makes sense. So if I see a reddened heel and I push it and it's non-blanchable, it is a stage 1, correct? That would be descriptive of a stage 1 wound. So if that is the case, or the first layer is taken off, or it's a non-stageable, however it is, look at each of those things and know what stage it is, so that if on a test or an NCLEX, if you're taking your boards, you will be able to know that's a stage 2 and what it's doing. If it's described to me what I see, what am I seeing? Or if they say, if you have a stage 2, what would you see? I want you to be able to do that. I hope this makes sense. If not, please reach out to me via email for my students. And if not, for those out there, there are other lectures with wound staging that you can access. Now, I've already said, let's go through and review your wound dressing change, because when you're doing wound care, you need to know how to, what to, and what we're doing. So you want to always, of course, provide or perform hand hygiene and use the proper PPE. If you've got a juicy, yucky, really lots of bleeding or exudate or a large wound, then you probably are going to need to put on a gown and put on an actual face shield, protect your eyes, because as you're down there working, pulling out old dressings and putting in new, you're down there cleaning the wound. You don't want anything to splash up in your face, into your mouth, into your eyes, on you. So wear the proper PPE and do it according. But if you have a little surgical that's sutured, that's been in, and you're changing the dressing, it's a dry dressing to this, there's no bleeding or exudate noted, it's closed or whatever, gloves are sufficient. Okay, so let's just talk about it. But you want to use sterile saline or appropriate wound cleansers to remove any contaminants when we're doing or cleansing a wound. If you're going to have to get a wound culture and you're collecting, and that's on down an aseptic technique, you want to use a sterile swab or syringe, of course, to sample the wound bed. But before you do that, you need to clean the wound, because you need to clean off the contaminant. If I obtain a dressing or a specimen and there's a ton of pus in there, or yellow exudate, or green, or whatever, and I swab that and send it down, that's going to give me a false, it's going to actually contaminate the specimen to see what we're looking at. You want to clean that wound first, with sterile saline or whatever. Use sterile saline for this. Clean it out, gently wiping, get out that other padding dry, however we need to, without damaging the good tissue. And then we would want to swab that wound and send that down. That culture should go down at that point. But we always want to clean it, and we clean it from head down, from the top of the wound down, always away from, right? We never want to go towards anything or into anything. Down and out and away. If we do send a specimen, make sure you label it, date, time, initials, and where. So if you get it from, they have 12 wounds, then we need to especially know where, but always put where, even if it's a single wound, where you obtained it. They need to know. Try not to touch any surrounding skin, because we have other bacteria and stuff that's on our skin, that's natural, normal flora, that can come in and contaminate that specimen. And then, of course, educate the patient for signs and symptoms of infection. That's redness, warmth, swelling, pain, or drainage. Anything coming out that should not be. And then if they are going to have blood or have serous sanguineous drainage for a while come out of this, explain that to them. But with wound healing, guys, it should improve. So if you have bloody drainage, that bloody drainage should slowly start to if you have sanguineous drainage, it's to start to become serous sanguineous and serous sanguineous to serous. You know what I'm saying? It'll start to lighten and thin because that's part of healing. Remember granulation, if we're looking at a wound or inside a wound, that we're looking at granulating tissue, little small pink looking bubbles, or it's healthy. Bleeding skin is healthy skin. Black, yellow, green, anything is not healthy. It needs to go. That's why we do wet to dry dressings. Just remember that. And you don't want to pack that wet to dry dressing down hard. I was doing wound wet to dry dressing checkoffs the other day, and I had a few students that wanted to really pack it down in there. Don't pack it so tight that you can't get the wicking to happen. That's why you fluff the gauze. It's wet, and you don't want it super wet. Wring it out good, fluff your gauze, put it down in there, and just make sure you don't put it on good skin. Pack it up to the top, put it down in there. Fluffy though. Don't pack it tight so it can't cause that wicking, because the whole goal is to pull and draw up into that gauze so that when you remove it, you're debriding. It's a debridement. Now, I'm going to say this, guys. Nowadays, we have so many other products out there to debride wounds that we don't necessarily have to do wet to dries anymore. We can wetten that wet to dry a little bit as we remove it so that it's not ripping or pulling good flesh or tissue, causing more bleeding and issues and more damage. We want to loosen it to pull it out. It's not going to hurt it to dampen it again. Use your saline and just kind of dampen it and pull it out. And then you're going to assess what you see on it, right? What do I see? What does it look like? All of that good stuff. Just know we have other stuff out there though that can be used that's a little more gentle on the wound, and it'll help with debridement a little bit different. And then of course there's always cutting and different things. Those are for specialties. Those are for specialists, people that have been trained to do that. They are certified in doing that. That's where your wound care nurses come back in. They're able to debride, and they go on to special certifications to do that with a scalpel and stuff. That is not for us to go in and just decide we're going to cut off the necrotic tissue. If you're in an area that doesn't have wound care nurses to do that, your physicians or providers will do that, not you as a nurse. That is not in your scope. So just making sure we are understanding on that.